we're going to look at the cyber attack that affected the health service in Ireland. I've changed the running order just slightly so as that to facilitate everybody. So if we can begin by, if I can introduce Ms. Tess O'Donovan, who is the Operations Manager for the South Southwest Hospital Group. Tess, I'll hand over to you.
Thanks. So thank you for the opportunity, Peter, and my apologies. I asked to start because I have to leave to go to another meeting. So again, in terms of the overview, you will hear from one of our ED clinicians, Professor Conor Deasy, and a hospital manager in South Tipperary University Hospital, Maria Barry, who will give you the real lived experience of what it was like in a cyber crisis. So from my perspective, we're the South Southwest Hospital Group. We are have a network of 10 hospitals that are spread across the geographical region in the south of Ireland. And when we were just trying to take a breath from COVID, cyber hit us. And I suppose there's a few key messages, and my colleagues will touch on them. It can happen at any time, and preparedness is one thing, but actual reality on the ground are two different things. So when you sit where we're sitting now and we're looking back, I think we can't underestimate the vulnerability of our systems and the direct impact on patient care and the risks associated with patient care. So our ICT infrastructure, I suppose, it is challenging at the best of times, and we have different levels of ICT infrastructure across our hospitals. Multiple systems that don't talk to each other, and we have a national system that sits over all our structures. So some of the complexities that happened in terms of cyber is our own ability in a region to be able to move through stuff and get things cleared, as well as our hospitals, their ability to manage complex patient care in the absence of any of the normal ICT supports that would be available. So on the map there, you see the south of Ireland, and the South Southwest Hospital Group is the area in yellow. Very nice place to visit. I'll always do the bit for the tourist board to come visit. So when cyber hit, again, it happened during the night. So that was one of the key factors that happened. We as managers would have got notification in the middle of the night to say this had happened, and the first protective measure that was taken was close all systems. So obviously when that happens, then you're coming into a workplace where there is no information available, only what you had printed before the system was closed down. So the risk to patient care was immediate. And as you will be aware, this is a system, that's, I suppose, a complex system anyway in health. So we now had a higher, I suppose, risk, and our clinicians were literally pen and paper is what we were back to. So working our way through that, our immediate response from the South Southwest Hospital Group was to come together into our incident room, which what it became, and to look at how we could communicate to our hospitals and how our hospitals could communicate to us. The national system response was unavailable for a period of time. So we actually, to be fair, had to develop very basic communication systems directly. And without that, we couldn't have functioned. We wouldn't have known what was going on in the hospitals. The hospitals wouldn't have been able to communicate with us, and we had to identify our priority areas. That was the first thing. What are our critical systems that needed to be prioritized? And then what are the systems that were gradually, and over time, systems were brought up. I think the biggest learning for us as a hospital group was the ICT risk matrix and the clinical risk matrix are two very different risk matrices. So when ICT systems were cleared and back up, it certainly didn't mean that they were available in the clinical environment. And that was something we struggled with for a period of time. And it was our risk rating. We standardized our work across all our hospitals. So we had one risk template for our 10 hospitals that we daily engaged with the national system prioritizing. But despite that, we still had radiotherapy systems that were there were 30 plus days before they were able to be enabled. And this is a brand new centre. So we had high patient risk in this area of patients who had started treatment delayed, and the associated risks of that, as well as simple diagnostics unavailable at hospital level. So the risk range, the patient type, and the profile was extraordinary. What I didn't have a complete overview of what systems, processes, and associated supports on ICT across all our hospitals. We now have that. We have a dashboard that's now giving me direct line of sight into what's available where, what are the interdependencies between different systems. And as I sit here today, there are some systems that are still not, I suppose, functioning effectively, for the want of a better way of describing it, who are slower, and we understand that because of all the virus protections that have to be put up, but our clinicians remain, there's still a level of frustration. And obviously the other big learning is that the reliance on systems, and when they're back up, the expectations that they'll be back up fully functional, they won't. So the advice from the hospital group perspective is plan for it, prepare for it. Your system supports, your cybersecurity systems need to be as good as they can be and more. We're still getting repeated, interactions from the cyber systems we've put in. We're getting reports of ongoing issues in the ICT system. Now, we have been able to defend the system, but again, it's the heightened awareness. It's not, I suppose, being as less vulnerable as you can be, but also to look at what are your backups. So even last night we had a systems failure. Now again, it was more technical rather than a cyber attack, but again, we had a whole system that was down for a period of 24 hours. There was no backup available for that system. So we need to invest across our hospital group and across the whole wider Irish health sector in terms of ICT systems. There's a reliance on ICT because of COVID. We were doing remote working, teleconferencing. So we were trying to utilize ICT systems as a modus of operandi and delivery of healthcare service. And that now certainly has been slowed down. There's certainly a mistrust in systems that, have come back slowly. And it is the strategy. There's an inevitability about it. There's actually statistics that would say once you've come through a cyber attack like we have, you're more vulnerable and potentially there will be more. So I can't underpin how important it is to have robust systems and security integrity across our ICT systems to protect it into the future, and to have a clear understanding from the ICT perspective what a system failure means at a device level to patient care in a hospital setting. Because I think that took a while to understand in the system. It might be one small system in one of our hospitals, but it was a big issue to the clinicians and the team trying to manage. That's me. Thank you very much.
Thank you very much, Tess. If we can, what we might do now is, if we move on to Maria Barry, if I could introduce Maria Barry, who is the hospital manager in Tipperary University Hospital. Maria, I'll run your slides for you. Just give me a second.
Okay, thank you, Peter. So as Peter has indicated, my name is Maria Barry. I'm the General Manager of Tipperary University Hospital, and I have been working in the healthcare environment for over 35 years, and I've been General Manager here in Tipperary University Hospital for the last 5 years.
There you go.
Thank you, Peter. We'll move on to the second slide there in relation to about the hospital itself. So Tipperary University Hospital is a level 3 acute hospital in a rural setting in the county of Tipperary. It's part, as Tess has indicated already, part of the South-Southwest Hospital Group. We have 206 inpatient beds and 25 day beds. We provide acute hospital services to a geographical wide catchment area of County Tipperary, West Waterford, and varying areas of counties Cork, Limerick and Kilkenny, and our catchment area will be about 160,000 depending on the speciality. We provide specialist care in medicine, surgery, obstetrics and gynae, paediatric emergency medicine, anaesthetics, critical care and radiology, to name some. So as Tess has indicated, the cyber attack struck on the May the 14th. And from my perspective as a hospital manager, I only became aware of it at 7 a.m. when I was listening to the national radio, and I became aware that hospitals in Dublin were cancelling their services. And I immediately twigged that there was an issue, and I tried to log on. I had been logged on the system from my home the previous night, and I tried to log on and there was no connectivity. So I immediately got into my car and came to work. I arrived to work, and on the way in, I suppose I was thinking about what really was happening, and I knew that we needed to revert to our manual processes. And to be fair to the staff, because it had struck during the night, there was an element that had already changed to manual processes as there was an issue with the system. So I suppose really I contacted our local ICT lead, who actually happened to be off on Friday. She came straight to the hospital, and I suppose, you know, we were quite reactive, very quickly used our boards here and behind my back to identify what could safely operate initially without any huge interference, and what, you know, where the interference was going to be on the system. And we then proceeded to have an emergency CMT meeting, and we met with the clinicians, because it was a Friday. We were going into a weekend of call, and you know, we certainly knew we were going to be challenged. And to be fair to everybody had manual processes for their department, but I suppose the problem lay in that where every manual process had to be used together. That was probably one of the biggest challenges that we had. As Tess has already said, it had significant impact for the service in delivering service, and immediately you're thinking about all of the risks, and the risks ultimately to the patient. And I suppose the first area that was affected, that caused most distress, was the patient administration system. Next slide, Peter. We were unable to register patients. We had no way of identifying the existing patients that were on the system, and you know, we had no access to online details for the patients. That had a serious risk for the impact of quality of care being provided, and the increased risk of harm. And even in doing the manual processes there, we were double checking and triple checking, because we were gone back very much to pen and paper, and that was the challenge. Pen and paper was certainly a big challenge for us. You're also thinking of not only the risk to the patient, but also the financial impact, both from you know, in relation to the hospital income and payroll and ordering. Our staff still expected to be paid, and that was going to be a challenge as well. The other big service that really was affected was the radiology service. We have a NIMS system, a National Integrated Medical Imaging System, that, you know, it connects us to all of the other hospitals, the HSE hospitals. And again, we reverted back to paper ordering. We had no electronic ordering. The consultants, and I'm sure you'll hear from Conor, where they had to literally go down to the X-ray department and to review the image on a screen. And likewise, the radiologists, consultant radiologists, when they were reporting, were looking at a screen in one room. We had no historical lookup. We didn't know what the risk of radiation exposure for repeated investigations was. So we were certainly, I suppose, operating very much in the dark. The laboratory system, next slide. I suppose again, you know, that we were challenged there. So immediately we restricted investigations to essential only. Internally, there was no external investigations available to our general practitioners. Again, you know, the risk here to patient care was we had no historical lookup. And, you know, all results had to be manually checked by two staff as they were being approved from a laboratory. Again, you're talking about handwritten labels and the risks associated with people's handwriting, because we're very much ICT. So diagnostic imaging as well was also a problem in the endoscopy suite. We have an EndoRad system, and that was one of the major clinical systems that remained down for a significant period and was a challenge. And still to this day is challenging, because we're only now beginning to upload what the work that was done during that period of downtime. So that you know, is a major issue from patient care perspective. Colposcopy area, and again, that system was down. We had no communication, as Tess had alluded to. We had no access to email. We had no methods of communication. We did use Gmail accounts, and thank you to our ICT lead. She set up Gmail accounts. And we were fortunate that, you know, that she was able to do so quickly. We had all PCs and laptops were switched off, and we had no access to devices on the network. And that was probably a big challenge, because actually it took a number of days before we were told that we could actually use our devices once they weren't attached to the network. But the initial advice was to switch off and stay switched off, and that certainly was a challenge. We had no access to public internet within the hospital. It was completely shut off, so that really challenged us. It took 3 days to get access. We had routers then, we placed them strategically throughout the hospital to try and get some semblance of communication across the service. Access to medical records, next slide, was disrupted. Again, we had no historical data. Without the systems, difficulty with looking up the medical records. Our work around that was we got onto the local radio here in County Tipperary, and immediately advised patients that if they were attending the hospital to bring an old record, to bring an old letter which would have had their hospital and the medical record number on it. So that gave us something to work from, but certainly was challenging in that aspect. As I said, the impact on service delivery, we immediately I suppose cancelled elective surgery and elective outpatients in the initial period, because we were challenged there from an outpatient's perspective with difficulty contacting patients. We had no way of contacting the patients. Although we did eventually find a list, and we were able to manage our outpatients for the intervening 2 weeks period before we were up and running there. We had no access to the payroll system, and as I said, staff still expect in a crisis. Now they're all working harder than they've ever worked, and they've been working very hard with COVID. And really it was the straw that broke the camel's back, in the sense that if we did not pay them, we were going to have other issues. So to be fair to the national system, there was a mechanism put in place there, which meant that our staff had to travel 200 miles to input payroll late in the evenings after working their day shift, but it was done and all staff were paid. The vaccination programme, and we are here in Tipperary University Hospital are responsible for vaccination clinic, and that however did work because it was cloud-based, so we were able to maintain those clinical appointments. Health and social care professionals continued to deliver their service. Local ICT worked, I suppose, put in huge hours to create alternative workaround solutions. And we did, as I said, put some strategically place laptops around the hospital to allow us, I suppose, one of the key areas was to maintain our bed management function and to maintain a record of what patient was where. And we literally set up an Excel spreadsheet and managed it throughout the days. By literally managing every patient on an Excel spreadsheet. We set up PCs with Linux boxes in the laboratory so we could get some historical lookup, and that was key from a clinician's perspective. At least now they weren't working completely in the dark, but certainly there was a sense amongst the clinicians here that they were working very much in the dark. And I suppose the big thing was, the immediate impact is you had no idea of how long this was going to last. You didn't know when you were going to be returning to business as usual. I suppose initially, because it happened on a Friday, you thought, look, we'll get over the weekend and we'll see where we're at. We never envisaged that the impact would be for so long and so difficult for us. As I've said, the clinical impact is, multiple systems are down. They're all down at the same time. You have no communication with Central, even though, to be fair to the South-Southwest Hospital Group, they did set up workarounds, but, you were really working very much in the dark. As I said, the financial impacts were also stressful, hugely a stressful event, I suppose. And it was, the protracted length of time, the fact that we did not know how long this was going to take, the fear of the unknown. We've never experienced anything like this. COVID was bad, but I think this was a bigger hit because of, it was just really, really difficult to get all systems working. We've coming off the back of the global pandemic and COVID, staff were extremely fatigued and tired, and now you were asking them to be extra cautious, extra vigilant, in relation to their manual processes, double checking, triple checking. So there was huge emphasis on that. We didn't know how long it was going to take to resolve. We had no idea really of the extent of the damage. As we were having CMTs, crisis management team meetings, we were hearing more and more in relation to the impact on services. So I suppose, you know, we have two major emergencies going on at the same time, cyber and COVID, and, you know, it was difficult to manage. We did get through it. Next slide. From our perspective of what worked well, you know, we have a small team. I think all of the staff worked very well together. We had each department had their own manual processes. They reverted to that, but I suppose how they interacted with each other we had never tested before, because we'd never had everything down together. And I suppose it did show us that we are resilient. We've gotten through it. The COVID pandemic, I suppose, meant that we were able to use our existing knowledge, particularly our knowledge around emergency planning, and, you know, we really kicked into action that morning very, very quickly. And, you know, we had quite a rapid response on the ground, and both locally and, you know, nationally. I think that, you know, everyone was working to try and address it. Internal communications were established very quickly. We continued to have daily CMTs, and we really brought those three core areas of patient administration, radiology and laboratory, because they're the big areas that were affected here, to our meetings, and we were able to work through you know, the problems and the issues, because they were also working with their various divisions and hearing things from national, so we connected it all together. And we had a good relationship with our external service providers, and that in itself was useful, particularly in relation to laboratory and the vendors. All departments, as I said, have had their own contingencies, but really to deploy them all together, you know, with one single failure was certainly a challenge. But we got through it. And I suppose our local ICT team and those from the National Service Desk here worked all hours. You know, they punched in a lot of hours for, I'd say, 2 to 3 weeks. They were working around the clock in relation to getting us set up, getting workarounds for us, and also then going through the process of cleaning devices, ensuring that devices were ready for use when the system was back up, when we were told we could log on to the network. Next slide. What we would do differently, I suppose, we have no public internet for communications, so I think that we've learned from that, and we have here in the hospital purchased 2 modems that allows us to have some internet, outside internet. We really feel that, you know, we need to invest in ICT and ICT stock, and you know, keep a backup of ICT equipment, so that we can deploy it in the event of an emergency. And that I suppose it's really around investment in ICT. And we have, you know, we need an established major emergency communication pathway from central. I suppose in order to receive real-time updates, we weren't getting real-time updates initially because of the challenges across the whole system. We would advocate that cloud-based solutions, systems, you know, that we shouldn't be totally dependent on the HSE infrastructure, and we need to start thinking outside the box from a central perspective. Central lists of all systems and supports we require, and I suppose to maintain a patient master index, and we're doing that now. We're maintaining a patient so that we won't be caught out again where we won't have healthcare records and we can't identify the patients. I think that is key here. We need to be able to identify our patients and, you know, have access to emergency patient numbers that we can deploy as well. And I suppose what advice do we have for other hospitals? I think, you know, the cyber attack can happen to any organization. And, you know, as Tess has said there, we need to be ready. We need to invest in ICT and infrastructure, and that's the big challenge here. And we need to ensure that we have, you know, that you have your manual processes in place. And I suppose the big thing is not only to plan, but to test them, and probably test them, you know, a number of them together to see how they actually interact and how they function. Next slide, and the slide after, the post-cyber issues. There are still challenges for us here as we move through the rest of the year. There has been systems performance. There's a slowness in relation to the antivirus agent that has been deployed. It has slowed down our systems. Clinicians are not happy that it's slow, but I suppose, you know, it is the protection that's on the system at present. There is a delay in setting up new staff because obviously permissions that were given to ICT here on the ground have now been withdrawn, and it's gone back into a central function, and so therefore it's certainly slow. We are still backloading some data into from our systems up from that time. Particularly, I suppose the big one is the endoscopy, the Endirad system. We're still working through what endoscopies we did at that time and putting them back up on the system. And that's a challenge for us, but we're working through that. There are some legacy systems still not restored that we're working through with ICT in relation to. And I think we still have the challenges around the wireless network system still remains down within the hospital. And I suppose the big thing, as Tess has also said, is the confidence of the staff in the ICT system. And our biggest fear is, could it happen again? And, we're after hearing there now that Israel is having a challenge. So, I mean, I think it's a reality for our healthcare system that this is now the new norm, that we're going to be hit regularly. So that's it. Thank you very much, Peter.
Thanks a lot. We'll take the questions at the end. Conor, can I ask you to take over and you can introduce Professor Conor DC is the clinical director here in university.
Thanks, Peter. So yeah, as Peter said, I'm clinical director for unscheduled care and an emergency physician by trade, and I'm associated with University College Cork, and you can see a picture of University College Cork there. And one of the founding fathers of University College Cork was indeed the founding father of digital computer systems, George Boole. And he worked in Cork from 1815 to 1864. And I can't imagine that he would have anticipated the impact that his work would have in terms of revolutionizing how we deliver healthcare, but also its vulnerabilities as we all experienced during the cyber attack. I'll take the next slide, Peter. So Cork University Hospital is a big hospital. It's the largest in Ireland, in the Republic of Ireland. It's got 630 beds. You can see down there, it offers tertiary and quaternary services for a population of about 1.1 million people. So where the ISO bar indicates on the map there. We're the busiest mixed adult and pediatric emergency department in the country. So we see around 68,000 patients per year. And of that 68,000 patients, 70% of them go home from the emergency department. 30% of them get admitted to an inpatient ward. And what we had seen in the weeks coming into the cyber attack was a step increase in attendances, which was probably post-COVID, peri-COVID, pandemic related. We were seeing a lot of increases in over 75-year-olds who had deconditioned during the 18 months of the pandemic. And of course, what that means when they're over 75 for us is they've got twice their average length of stay to somebody who's less than 75. And they have a complexity of need, a complexity of requirement, and they also have a past medical history that we rely on in terms of making decisions real time for those patients. And the cyber attack blinded us to their past medical history. So this is the registration desk at Cork University Hospital. It was quite this last night when I took this picture, but generally speaking, there would be 2 to 3 people registering patients, about 240 a day, registering patients at this desk. You can see the items of information that they get from the patient and type in real time into our IPMS information system: name, telephone numbers, dates of birth, age, sex, occupation, religion, medical card number, insurance status if they have. You've got next of kin information, you've got their GP information. Turn off all computers and all this is being done manually. And of course, it is liable for transcription and errors and for legibility issues afterwards. You also see there on the front cardex the triage nodes. So the nurse, while she's triaging the patient, types in real time the triage category using the Manchester triage system, what the patient's blood pressure, heart rate is, and that populates a screen that is then visible to us throughout the department. So I can look at what's in the department, what their physiology is, what their triage is, when IPMS is up and running. Turn off IPMS and I'm in the dark. I don't know what is in my department without going around and visualizing everything. One of the other things you saw on that previous slide was the Visa machine, which is used for taking payments. And of course, Visa 2 was disabled as a result of the cyber attack. Not a big deal for us, but it's just yet another thing that that impacts. Sorry, Peter. Thanks. Go ahead. So we were never a particularly sophisticated emergency department in terms of IT. We have been crying out for IT investment for some time. There is a plan to invest in an acute floor information system at COH, which would take away our requirement to have the whiteboard that you see there on front of the clinical nurse manager. So that clinical nurse manager with the blue cap is got on front of him a whiteboard which contains all the patients in that section of the emergency department. He's got ambulance arrival screens that you see in the blue, and he's got IPMS, which connects him with the patients that are registered on the left-hand side of that photograph. So despite us being a relatively, a relatively old school, paper heavy emergency department, we were still floored by the cyber attack. One of the key things that challenged us is in a hospital the size of COH, that when we, for example, admitted a patient, they would go to a ward, and it was very challenging to keep on track of where these patients were going in the hospital, and if there were movements within the hospital, where the patient would move, if they were moved from one, from say, for example, theatre or theatre recovery to a ward. We would, in the emergency department, receive phone calls about this patient's blood test results. We would receive phone calls from family members wondering how their loved one was doing. And it was, it was very challenging then, not being sure where that person was. So we had to put in place runners and centralize a hospital census that would be maintained as up to date as possible. Just before you move on, Peter. So that we had visibility of where patients were at in the hospital. Paul also, that guy that you see on the computer there, he also is required to go and find the charts for us when a patient is when we need a chart, when we need one of those old paper-based records to figure out that past medical history, their previous diagnostics, what cancer diagnosis they've had, what cancer treatments they've had, and so on. But you can move on, Peter. But Paul needs to have the hospital number for that patient in order to find out where their chart is. And he also needs to have access to the chart library to know where in the hospital that chart is stored. And of course, we had neither when cyber attack came. So we initially switched to emergency record numbers, which in retrospect, we would think again about. Subsequent, when we realized the problem here, we did a lot of media work asking patients to bring in with them any correspondence they may have had with the hospital in the past. We spent time getting onto their GPs because we wanted to see if we could track down their original medical record number so that we could in turn track down their hospital chart. But again, very difficult because all these libraries are held on a computer, and as Maria described and Tess described, all computers were shut down. All computers were shut down. There was no opportunity even to bring in your personal laptop, even if that was useful. And that was what we were experiencing for the first few days of the attack. Thanks, Peter. So what you see here is what we reverted to in the first few days, writing on these blood bottles according as we were doing investigations. We would normally, obviously, order blood tests on a computer system, print off a label and put the printed label on the blood bottle and send it via the chute to the lab. All that was knocked out. And when the lab therefore got their hands on these bottles, their automated processes weren't possible. They had to read them manually. They had to enter them manually. And of course, lab turnaround times were extremely delayed. And that led then to extreme delays in the emergency department processing patients, trying to figure out important blood test results that would inform the direction of treatment of that patient. ECGs, again, trying to see whether a patient had old ECG findings was impossible because we couldn't get at their old chart. We couldn't get at the digitally held ECGs that were on the system. Our ECG machines speak to the computer system and they get uploaded to that. Again, that was disabled. So we have 29 days where all those patients who did present to the emergency department didn't have these ECGs sent to the system, and we have to catch up on all that. Next slide. Thanks, Peter. Okay, so what you see here is one of our junior doctors who is sitting down, writing her notes, having gone to the patient, examined the patient, taken a history. She's now documenting that history, and she's referring to the computer system where you can see there's records there of various interactions that patient would have had, various blood tests that patient would have had. She can see on the computer the CT scan that patient would have had, old medication lists, all any previous attendances at the hospital, who those consultants were, any future attendances due at that hospital to see who that patient has been referred to. All that information was turned off as a consequence of cyber. We didn't have it. And you are literally flying the airplane with your eyes closed when you're trying to offer modern healthcare without that information. Next slide, Peter. Next slide. So as Maria alluded to, we had to go down to the X-ray area at the same time as the X-ray was being done so that we could see the X-ray real time. That obviously delayed us tremendously in terms of processing patients. We established a workaround in terms of X-rays whereby we managed after about 5 to 7 days to get a hard drive made available to us of old imaging. So we would be able to look up old imaging that a patient may have had. But that took a number of days to have happen. The other thing that the other workaround we had was we had to run a cable from the CT scanning area back to the emergency department so that we could review CT scans in the emergency department. But that was done with a hard cable. And again, that took time to establish, but was very helpful when we did establish it. Thanks, Peter. So monitoring of patients. So as you can imagine in a COVID time, what you're seeing here in the picture is a patient who is infective. I've just had the doors open there so you can see that the nurses are able to stay out of that room and keep an eye on the patient remotely. And that reduces their exposure to, to a patient with COVID. Obviously with IT systems down, the nurse then had to go into that room and be there and be present and be more involved, be more face-to-face, spend more face-to-face time with that patient, which obviously increased their exposure and their risk to COVID and infectious diseases. You also see their telemetry. Telemetry was also disabled as a consequence of the cyber attack. So we were not able to monitor patients who may have an acute coronary syndrome remotely. We could only monitor them on their own monitors. Normally, you would see a bank of these monitors in a central location where a nurse can keep an eye on 6 patients at a time on their monitoring screens and quickly check if they went into any sort of arrhythmia. That was disabled as well. Next slide. Telephone systems. Some of the telephone systems were on computer networks, so they were disabled. And so we were relying on mobile phones, but, mobile phone, in terms of mobile phones, I don't have a mobile phone number for the registrar in orthopedics who's on today. I have no idea what registrar in orthopedics is on today. I need to check the computer to see who's on call for orthopedics today. So all this stuff that we would take for granted as part of our working day was annihilated. We did ask patients not to ring the emergency department because we were struggling so much ourselves in terms of relying on having the ability for the lab to ring us if there was abnormal blood test results and so on, and we didn't want our phone lines in the hospital getting used up answering patient queries unless they were true emergency queries, and that obviously caused considerable blowback from the population that we are here to serve, concerned families ringing about loved ones who didn't understand the crisis that we were going through. And so again, the media messaging was very important in that regard, to explain to them that the hospital was literally under attack, that we needed to consolidate, and this is why things are the way they are in terms of poor telephone response rates and so on. Thanks, Peter. So again, just another example. This is just one of our Kanban units that contains stock. Trying to order stock was challenging. Trying to keep on track of the amount of stock we did or didn't have was very difficult. I'm showing you an abacus there. It's not that we have, as I said, a very sophisticated system, but the system we had allowed us keep going. You know, we ran into trouble where our way of ordering stock is computer based, and so even knowing the phone number to ring to order stock was very challenging, and these things didn't stabilize until well into 5 to 7 days of the cyber attack. Next slide, please. Okay, so as I said, the registration systems, the test ordering and the reporting of the tests reverted to manual and paper-based, and these are error-prone. We discovered people's bad handwriting. We discovered legibility and transcription issues, and it's extremely slow. It's extremely laborious. We need extra hands on deck, and you can't easily find extra hands on deck to service a situation like this. As I said, we had no lookup. So the majority of patients, what we found is if we gave them new MRNs, that then created other difficulties in terms of trying to reconcile their patient incident with their past attendances at the hospital, and that subsequent merging was extremely difficult. So as I said, one of the take-home messages from this is try and have patients bring their own medical record number to the hospital, or else invest in people to ring their GPs, ring their families, to try and establish any old MRNs. We needed to use a lot of runners to transport diagnostic tests and results, and they again took a number of days to recruit. We recruited students, science students, medical students. There was some degree of redeployment of certain staff. So for example, secretaries who are now not getting their dictation, or they were now not having to do dictation because the computers were down, were redeployed as runners and to support admin staff. As I said, the hospital census was a really challenging piece of work in a hospital our size, and tracking patients through the hospital was very difficult. It took 3 runners going pretty much full time to keep site locations updated. We had daily executive meetings with crisis team. As I said, we redeployed staff. The laptop piece is an important one. We didn't have a stock of laptops immediately available for us that Friday morning that we could automatically go to laptops and start digitalizing the registration of patients onto an Excel spreadsheet. We subsequently did get to that, but in the first instance, we were relying on manual. And the reality is you're not going to have that number of laptops in stock, in store. necessarily to replace the entirety of a hospital the size, or a health system the size of our health system. And so that took time to mobilize. T-Pro is a dictation system that we use, our doctors use, for sending out letters to family doctors, letters of referral to other doctors. And we found actually that we were able to use that to track back old correspondence to do with the patients, and that wasn't affected by the hack. So that was a facility that we used to look up old MRNs and was very helpful. As I mentioned, we got historic labs through a hard drive with a dedicated screen placed into the emergency department, and we got historic radiology via a hard drive with a dedicated screen put into the emergency department, and these helped a lot. We used Silo, which is a medical WhatsApp device, to replace our referral system to our virtual trauma clinic and our fracture clinic. And if any of you haven't seen it, it basically allows you to take a picture of the x-ray, put in some narrative, put some patient details in, and that's what we use as a workaround in the absence of our digital referral system for our trauma clinic. But all this stuff took a number of days to put in place. Thanks, Peter. Okay, so we were relying in the first instance on people doing overtime, and as people have already described, people were exhausted in terms of where we were at in the pandemic, and then this came upon us. So we were relying on them doing overtime, working over and above. We used agency staff from various sectors, and we redeployed whatever staff that were basically made redundant by the cyber attack into areas where we could get better value out of them. We recruited students as medical lab assistants to manage the significant increase in processing times for all diagnostics. Radiotherapy was a particular issue because all those radiotherapy plans are digital, and many of those patients had to be replanned, and that activity was sent to the private hospital because our radiotherapy facilities, ironically, they're brand new, but they were vulnerable to this attack, and they were taken out. So that radiotherapy activity was sent to the private hospitals, as was some degree of elective surgical activity. One of our problems we felt was that the public didn't really recognize the enormity of the impact of the cyber attack on the hospital and the healthcare system. So we put a lot of effort into engaging with the public via the media, TV, radio, newspapers, social media, and even sandwich boards in the emergency department. And you can see here, this girl, Mary Randalls, tweeted the day of the attack: clerical staff volunteering on wards as runners, porters clocking tens of thousands of kilometers, radiology registrars in the emergency department reporting x-rays, and interns flying around the hospital to make sure patients were cared for. Just the tip of the iceberg. So that gives you a sense of what the hospital was like real time. And so we appealed to the public to only use the emergency department for emergencies. I know that may sound, like a strange thing to say, but we do find that people in our jurisdiction use the emergency department because they can't get into their GP, they won't wait to see their GP, and so on. So we appealed to the public to try and maintain the emergency department for the sickest situations, and explain to them the delays associated with the cyber attack. Thanks, Peter. Again, some more public messaging. Spokesperson added that some changes will apply from that patients with an outpatient appointment, chemotherapy appointment, surgery appointment should come to the hospital unless they were contacted to cancel. Patients with x-ray appointments should not attend unless contacted, and radiotherapy appointments are cancelled. So very unsatisfactory. A lot of very unhappy patients rocking up for their x-rays or for their radiotherapy with their new cancer diagnosis. high emotionally charged interactions with staff, and we have to wear that. But as I said, we did our best to try and use the media to help us with the public messaging. Next slide, Peter. Okay. So again, what we asked in terms of the public messaging was to try not to come to the emergency department unless you really had to. If you were coming to the hospital, bring any old correspondence that you could that may have been received from the hospital. Even appointments would have your hospital record number on them. Bring lists of medications that you have with you to the hospital, and we asked them to expect delays. So we were trying to manage their expectations. Thanks, Peter. So if I knew then what I knew now, so I'm actually going to give 4 things, I suppose, really. Asking patients to find their hospital identifier is better than rushing them through on new identifiers. And I think that's a key learning point for us. The new identifiers, we had obviously practiced this as part of emergency medicine planning, that you would issue new identifiers. But when this is a prolonged incident, that caused a huge amount of difficulty in terms of reconciling charts with emergency numbers, errors in transcription based on a handwritten system. All these issues could have been somewhat mitigated if we had invested in admin staff, ringing people's GPs who weren't urgently needing an MRN, where there was a few minutes where you could do a bit of detective work to try and establish an old MRN. We felt our staff well-being, that it's important to look after your staff across the board, be it in particular the administrative staff that support us delivering care. We found that during the cyber attack, we sort of we exposed their anxiety levels, with some of them really finding it very difficult to work under these circumstances. We found that it exposed reading difficulties with some that wasn't exposed on a keyboard. So some had no issues working with a keyboard, and then you ask them to revert to a handwritten system, manual system, and lo and behold, you discover they've got a dyslexia. And similarly, their legibility. So these are things that get exposed at a time like this, and having eyes open across leadership within the hospital was important, and providing them with coffee, lunches, and so on went a very long way. This risk was accumulative. Errors were accumulative. The longer it went on, the more risk there was. And I suppose what is amazing is the recovery time that is associated with the downtime. And so I suppose when you think about that individual, Greg, registering patients, all those pieces of information that he is taking manually from that patient, and that there are 3 Gregs working simultaneously across the, nearly across the 24 hours, not quite, then it's going to take quite some time to recover, if your recovery is based on office hours, or if your recovery is even based on extended days. It's going to take a significant amount of time to get that information back in a digitalized form. Thanks, Peter. And that's it from me. Thanks for your time, and happy to take any questions. You're on mute, Peter.
If you go onto the website for the National Cybersecurity Centre, you'll see the notifications that were handed out there. So if you have technical questions as to exactly what happens, it's all set out there. It's all available in the public domain. And at the moment, it's only what's available in the public domain of what happened precisely. But basically, the National Cybersecurity Centre issued information within a day or so. They instructed us as to what we knew would happen, which is contain, eradicate, and recover. And they also indicated they also gave us what are called the indicators of compromise, which tell us if our system is compromised or not. We saw this earlier on, where we have a national complex and integrated national system. We also have detailed HSE national IT protocols and standards. They're all publicly available and they were all followed. And so and that is all available if anybody has specific information about it. But basically what this was a 0-day threat with a brand new variant of a Conti ransomware. A ransom was sought but not paid and will not be paid in line with state policy. The cyber attack did not impact the ambulance 112 or 999 system because that was a separate system. We also used the opportunity of having a backup in Belfast where we sent a number of call takers and managers to manage that. And it was a useful test to see if that would work. And as we mentioned earlier, the vaccination program, which is a cloud-based system put in specially for the vaccination, wasn't affected. This attack we're told, took place as a result of the Conti wider, what's called the Wizard Spider gang, who were believed to be behind the attack. They found a remote access tool called the Cobalt Strike beacon on the system, which hackers used to move within the computer networks before launching their virus. And the talk on the street is that they were in the system for some days before the attack came. A decryption key was provided, it wasn't paid for. The state's cybersecurity response team, along with the commercial IT contractors, FireEye, or also known as Mandiant, and international partners have been working on 24-hour shifts so they can use it on the HSE system to decrypt, and that took time. And we also did what was called a super injunction. That was important because what it means, and it was the first time kind of from a historical legal history kind of view, is that the HSE managed to get what's called a super injunction against persons unknown. Normally you get an injunction from the courts against a specific individual, but this was persons unknown. And the main purpose was to put the legitimate information service providers such as Google, Twitter, Facebook on a notice of legal prohibition on the sharing and publishing of the HSE information. So that seems to have worked. The advantage that we have there is that the European headquarters of Google, Twitter, and Facebook is in Ireland. So that's from our point of view. The attack went on forever. There's the famous words about the First World War, it'll be over by Christmas. We're used to cyber incidents being fixed quickly. On the 24th of June, which was 6 weeks after, we had 78% of the servers are decrypted and 76% of the HSE devices are restored and connected to the HSE network. And to a certain extent, as you heard from everybody earlier on, they still haven't hit that system. And very recently, the Garda Síochána, which is the Irish police service, managed to take control of some of the gang's websites, which were used against the attack in May, which is months later. So I think the overall message is that that's what it would be. So I'm going to stop sharing.